Okay. Good afternoon, good evening, everyone. I'm Professor But a chair of the ISN OSCA and ISPD Asia Pacific Chapter Regional Board. Welcome to today ISPD Asia Pacific Chapter and ISN OSCA PD case discussion. Thank you for joining us from across the region, whatever or wherever you are. And today's session is the many ways to skin an infected catheter, adapting guidelines to real-world experience, presented by Dr. Chiru and Professor Marjorie from Singapore General Hospital. We also have live question polls during the session. Please join in so we can make this as interactive as possible. Feel free to raise your hand or drop question in the chat. Just tell us your name and where you're joining from. And also the teaser I will insert into the chat box. Please feel free to download there. And what's that? Let's get started. Dr. Shilu and Professor Marjorie, over to you. Please, thank you.
Thank you very much, Professor Golf. Okay, so good afternoon, everyone. The title of my talk is The Many Ways to Skin an Infected Catheter, Adapting Guidelines to Real-World Experience. This talk is about surgical interventions for PD catheter-related infections. The ISPD guidelines provide
Sorry to interrupt, there's some echo. I think can you switch one of your computer there? There's some echo in your presentation. Thank you.
I think off. I'm not on. Okay, try again.
Okay. Okay. Hopefully it's better now. So basically this talk is about surgical interventions for PD catheter-related infections. ISPD provides some guidelines for surgical interventions when these infections fail to respond to antibiotics, but oftentimes in the real world, it is a bit more complex and there are many other factors that come into play, such as the patient's comorbids and the patient's preferences. So in this talk, I will be discussing 3 different cases where it wasn't so straightforward to follow the ISPD guidelines, and hopefully in the process to highlight some of the complexities and considerations involved in the decision-making process, whether to intervene surgically or not for these infections. Okay, so firstly, just a brief introduction of catheter-related infections. We can classify them into exit and tunnel tract infections. Exit site infection is diagnosed clinically by pus discharge from the exit site with or without erythema of the skin at the catheter epidermal interface. Tunnel tract infections can be diagnosed clinically either by redness, induration, swelling of the skin overlying the tunnel, or radiologically, which is via ultrasound showing collections in the tunnel tract, which can be further classified based on their location in correspondence with the 2 cuffs, either superficial or deep, corresponding to the external and internal cuffs. Another way to classify these infections is based on the frequency of occurrence. So as you can see on the table on the right, if these episodes occur within 4 weeks of each other from the time of completion of therapy of the previous episode, in 2 different organisms, is called recurrent. If it's the same organism or one of them has no bacterial growth, it's called lapsing. If the episodes are more than 4 weeks apart, we classify them as repeat. And if there is no resolution between then we classify it as refractory. Okay, so what do the guidelines advise when to intervene surgically for these infections? Firstly, if there is an exit or tunnel tract infection that either progresses to or simultaneously occurs with peritonitis, and you have the same organism isolated from both the fluid culture as well as the exit site culture. Secondly, if it's refractory. So ISPD loosely defines refractory as basically failure to completely resolve following a recommended antibiotic course, which I will go later on. What is this recommended antibiotic course? And what do we mean by surgical intervention? Firstly, and simply, the most simple thing would be to take out the catheter in its entirety. But there are also other techniques where allows us to preserve the patient on PD, which I'll go through in my talk. So basically, for exit site infection, recommendation for treatment is 2 weeks, except for Pseudomonas, which is 3 weeks. And as I mentioned previously, surgical intervention is recommended if there is concomitant peritonitis or if it's refractory, in other words, failure to respond after the recommended 2 weeks or 3 weeks for Pseudomonas. And for tunnel tract, recommendation for treatment is at least 3 weeks. And again, surgical intervention is recommended if concomitant peritonitis or refractory. In this case, the for tunnel tract would be 3 weeks of antibiotics. So this is based on the guidelines, but in the real world, it's not so straightforward, and there are many other factors that come into play. And often it's a balance between removing the catheter and not removing the catheter. In other words, trying to preserve the patient on PD for as long as possible. So what are some of these factors? So factors that will push us to remove the catheter and therefore convert the hemodialysis. Firstly, severity of infection. If the organisms are very resistant, known to cause biofilm, like I mentioned previously, concomitant peritonitis, or if it's refractory, especially when there's persistent pus, the collection charging on the ultrasound scan, that would push us more to remove the catheter. Alternatively, if the patient is already not doing well on CT, that would also push us more to convert the patient to hemodialysis if there's an ongoing infection. So what do we mean by not doing well on CT? So for poor membrane viability with very poor solute clearance, recurrent fluid overload, or prolonged PD vintage with high risk of EPS. However, there are also factors that will make us more likely to try to preserve the patient on PD. Firstly, if the patient is not a good candidate for hemodialysis, for example, high risk of hemodynamic instability, very poor, low residual renal function, risk of fluid overload from further loss of residual function on HT, and if the surgical risks are high for going for catheter removal and insertion. Also, we need to consider psychosocial aspects. For example, if a patient has it's going to be very difficult to reinsert the catheter, like the patient has background of polycystic kidney and liver with no space, and after we remove, there's going to be that we may not be able to put in another catheter, then we may not be able to get the patient back on PD ever. And also, hemodialysis is more costly, and elderly patients may have issues traveling to dialysis center compared to doing it at home. Of course, there's this in-between option where we can intervene, but at the same time, preserve the patient either through catheter salvage or through sematic removal and reinsertion. We go through in my talk. So basically, let's go to it. So basically, these cases are meant to be interactive. There's a poll with multiple choice questions that you all can participate in. So this case is a 51-year-old lady. She's still working as an accountant. She's divorced and she's the sole breadwinner of 2 children. She has a background of ESKD secondary to retirement property, for which she has started on PD since 2021. Of note, she has this very interesting condition called sympathetic dysautonomia, diagnosed back when she was 19 years old. So essentially, her autonomic nervous system doesn't function. So she has neurogenic bladder, she cannot sweat, she cannot produce tears, and she also has irritable bowel syndrome. And she's on self-catheterization for her neurogenic bladder. She has been quite euvolemic, and these are some of her latest blood tests for renal panel. As you can see, the urea is a little bit high, but still reasonable. But she's actually on a very high therapy volume on the FMC system, total volume of 9 liters, relative to her very low body weight of 39 kg. She presented to us multiple times over the course of the 4 years for past discharge from the exit site. So as you can see here, the red wound stock cultures are basically those that grew organisms. And all the organisms were actually MSFA, except for the last episode on the 9th of July, which grew this organism called Borsa. So Borsa basically is borderline oxacillin resistant. In other words, it's in between MSSA and MRSA. MRSA basically you cannot use beta-lactam. This one is borderline sensitivity to beta-lactam. So for all the MSSA episodes, she was treated with various courses of cefuroxime, except for the BORSA episode for which intraperitoneal vancomycin started. For some of these episodes, we did a scan at the end of the cefuroxime course, which showed collections, and this is the assessment at the end of the various courses of antibiotics. So basically, you can see here, firstly, there's a refractory tunnel tract infection since 2023, where the collections have been enlarging on serial scans, and the final involving the entire catheter. Secondly, just before the BORSA episode, in February, there was this episode of refractory exit site infection where there was persistent pus beyond 3 weeks. And finally, we see that the last episode, now this Staph aureus has become a resistant species already. So for this final episode, this BORSA was given 1 week of IP Vanco, but after that, the scan showed that the collection got even bigger and there was still persistent pus. So this is the BORSA sensitivity, and she was given 1 week of intraperitoneal vancomycin, and there was still pus, and the scan showed a very big collection along the entire catheter, as you can see from the diagram here. So this is the exit site, this is the internal cuff, and above the catheter you can see the collection stretching across the entire. So so this question basically, in summary, this patient has MSSA infection 4 years, it's refractory with tunnel tract collections. Now the organism is resistant. You gave her 1 week of IP vancomycin, but there's still pus discharge and a very big collection. She has been counseled multiple times to remove the catheter for the last 3 or 4 years, but she's refusing because she works, and when she does hemodialysis, she cannot work and she cannot with doctors. So what would be the best course of action at this point in time for her? So there are 4 options. I'm not sure whether we can activate the poll.
And the host, Golf, can you activate the
Yeah. I can hear you, but actually, 4 questions that come to the same time. So I talking with my technicians to run one by one.
Otherwise, I can just go through the answers.
I go to the answer for the question one. For the second one, I will ask him to reply.
So basically, in this case, the best option would be to remove the catheter, convert to interim hemostasis, and then reinsert. So option A is basically just persist antibiotics, which is not the best option because, as you have seen, it's a refractory collection for 4 years. Now the organism has mutated to a resistant Staph aureus. The collection is getting larger, and so without proper intervention, there's going to be risk of peritonitis. The second option is basically to permanently switch her to hemodialysis, but firstly, the patient doesn't want because she needs to work. So in this case, we see that we need to take into consideration the patient's preferences. And secondly, we saw that her renal panel is not that bad. She's only 4 years on PD, so the risk of EPS, membrane failure, is not that high. So it's reasonable to reinsert the catheter after we treat her for about 2 weeks, which is the right answer. Option D. So option D. So option D, basically, spontaneous reinsertion in this case cannot be done when there's internal cuff involvement. So in this case, the collection is across the entire catheter. So whenever there's internal cuff involvement, we usually don't do simultaneous reinsertion after removal. Okay, so the case progresses on. So we took out the PD catheter as discussed earlier, and then we the tunnel hemodialysis.
The pool is working now, so we can run one by one. So do you want to go to the pool?
I think we can maybe, because I already went through the answer, so I think maybe we can do it for this second question.
Okay, that's fine.
So basically, the patient had a tunnel dialysis catheter for hemodialysis, but 2 days later, she had very bad facial swelling on the side of the hemodialysis catheter. When they took out the Tenkov peritoneal dialysis catheter, the intraoptic culture was actually negative, and there was no sign of peritonitis. The cell count was 0. So because of the facial swelling, we did a CT thorax, and basically what you can see here is that this IJ, where the tunnel hemodialysis catheter is actually being compressed anatomically by the clavicle and the innominate artery. So, and this is made worse by the existing hemodialysis catheter, and that's why she got swelling. So now she has very bad facial swelling, concerned about venous obstruction. What would be the best course of action? So maybe we can activate the poll here.
Yeah, the post is active now. Oh, yeah. Oh, good.
Can?
Okay. Show the result.
Show the.
Is there a result?
Okay. So most people say remove, insert femoral, non-tunnel, reinsert Tenkov 2 weeks after 2 weeks of vancomycin. Is that correct?
Okay, yeah, so I'll go through the
Is
correct
that
option is actually option C, which is to remove and reinsert the catheter ASAP. So yeah, so I'll just go through the various options. Okay, so the important thing here is that the patient actually refused for setting after she developed this bad complication lah. So option A and B is essentially persisting with vancomycin and trying to keep the current TDC until we manage to reinsert catheter. But as we know, SVCO in this case can be life-threatening if it progresses, and so we should remove the TDC tunnel dialysis catheter as soon as possible. So that leaves us with option C and D, which I think most people chose. So option C is possible because the tip culture, as I mentioned, is negative. There's no sign of PD peritonitis, and so we can consider reinsertion earlier compared to the recommended guideline of waiting for 2 weeks lah. B, firstly, the patient refused for the line setting. So in this case, if the patient refused, we cannot insert the femoral line and try to wait for 2 weeks. And secondly, also because the tip culture negative, no peritonitis, we can actually consider inserting at the same time. And lastly, femoral line only lasts for a week, but the guidelines recommend waiting for 2 weeks. So this will involve repeated line changing with risk of line sepsis. So the best option will be option C. Of course, both C and D are quite close lah. Yeah. So basically, this is what we did. We quickly reinserted the Tenkov catheter because the tip culture was negative, there's no peritonitis, and because of that complication from the hemodialysis catheter. And she was very keen to go back to work actually because she's a sole breadwinner. So we started her on low volume PD and we discharged her. But 1.5 months later, she represented that for blocked Tenkov catheter. Basically having multiple alarms on the machine, and when we tested the catheter flow manually, the outflow was very sluggish. And she was very angry because she said that her old catheter for 4 years, there was no problem. And now 1.5 months after inserting a new catheter, she runs into problems with the flow. So anyway, we did abdominal x-ray. So as you can see here, the actually in the right position in the pelvis. But what you can see here is there's a lot of loading. So we tried to clear the bowels, but if you recall, she has this history of dysautonomia. So essentially, she cannot control her bowel movements, and that's why she ends up with very bad constipation. And so we couldn't clear her bowels, and eventually she underwent laparoscopic adjustment. So essentially, it's very interesting. This is the post adjustment at the bottom, and what you can see is that the right fallopian actually invaginated into the PD catheter hole. So the top photo is before adjustment, and bottom photo basically you can see the fallopian tube being freed from the catheter. So the diagram here just shows that the fallopian tube is its location in the pelvis, and essentially the pouch of Douglas where the Tenkov catheter is just where the fallopian tube is lah. Yeah, so basically the two are actually quite close together, and it's easy for the fallopian tube to invaginate with the Tenkov catheter. So basically, I just wanted to highlight that, as you can see here, after we reinsert a new catheter, there can be problems with, like, for example, flow. So how do we decide then whether should we reinsert a new catheter after we remove it, or should we just keep the patient on hemodialysis after we remove the catheter? So both of them have issues of their own. With catheter reinsertion, there can be early and late complications. So early would include bleeding from scar tissue, leak when the patient doesn't want to be on interim hemodialysis for a long time and wants to start PD earlier. Of course, with one infection, another infection can happen, malpositions from previous insertion, adhesions from previous insertion, also EPS risk if the PD vintage is prolonged, and of course, psychosocial issues. Late complications are essentially the same as early complications, with the addition of loss of residual renal function for patients who have been on interim HD for some time before we reinsert a second catheter. So then, should we keep the patient on hemodialysis permanently? Well, hemodialysis also has issues. So loss of residual renal function, hemodialysis is more expensive. There's also greater hemodynamic instability, and of course psychosocial issues, like, for example, with hemodialysis, you need to travel to dialysis center, more inconvenient. People may experience more fatigue, and so basically trying to show here is that eventually it's the patient's preferences and the patient's comorbids that will direct us to decide one as opposed to another. Looking at studies which has better outcomes, whether we reinsert the Tenkov catheter after we removed it, or should we leave the patient on hemodialysis permanently. So basically the first point is that reinserted catheters can have limited lifespan. In one study, more than half of the reinserted catheters actually lasted for less than 1 year. And this second one is our local retrospective study. Basically showed that within 12 months, it's very good technique for post-reinsertion. But the median time of failure for the second catheter was only 6 months, and most of those with technique failure that converted to HD were either because of second infection or catheter malfunction. Interestingly, another study showed that only dialysis vintage predicts technique failure after we return back to PD following catheter removal. And finally, studies show that actually the mortality is similar. So one study showed no statistical difference in mortality. Another case control analysis showed comparable survival. Okay, so we move on to another case. So this is a 46-year-old lady, ESRF secondary to FS.
Can we stop for a while? Just in case the audience want to raise any comments on the case number 1. So you how many cases that you have?
I have 3 cases.
So you have 2 cases, right?
Three cases.
3 cases.
Yeah.
3 cases. So anyone want to comment on the first case?
Hello. Question. Sorry.
Can you hear me?
Yeah. Yep.
Hi, Dr.
Very well.
Hello.
Please.
Okay, hi, Dr. Azwini here from HKL, Malaysia. I want to ask regarding the first case. When patient had the recurrent exit infection, other than considering Tenkov removal, discussion with the patient, did you guys consider anything like decuffing or the roofing procedure, or is already done but not mentioned?
Okay, so basically in this case, the collection involved the entire catheter. So it's the entire length of the catheter. So basically, when there's deep cuff involvement, we usually, in our center, we don't do decuffing or deroofing or exteriorization. However, if actually the second case basically is a case where it's limited to the external cuff, and in those cases we can consider those techniques that you mentioned.
Because I thought when it was just the external, understand when it's internal cuff. Okay, so the cuff use has 3 cuff, is it? External, mid, and internal.
Our catheters have two cuffs, external and internal.
That is okay. Okay. Yeah.
Uh,
Okay.
yeah,
Is
this
it?
basically midpoint of the catheter. Sorry, it's not like
Okay. Okay.
internal cuff and the mid catheter.
Okay, thank you so much. Lily?
Yeah, hi. Thank you for presenting the first case. May I know, because I noticed that you all provided the patient IP, intraperitoneal antibiotic for the exit site infection. Can you just highlight to us why it was not given intravenous, but instead given IP, and is there any studies to show the difference between the two route of intravitix?
So basically in our center, we use intraperitoneal vancomycin because it's convenient. The patient doesn't need admission, and we usually check the blood level of vancomycin to make sure that the levels in the blood are within the therapeutic range. So as long as the levels in the blood are in therapeutic, then we kind of extrapolate that the blood levels are okay and it's similar to IV. Of course, the best would of course be to give IV because IP is for intraperitoneal peritonitis, but it's mainly for convenience sake. As for studies that whether there's any difference, I'm not very sure.
Yeah. So for me, my personal view, because this case is quite interesting, because not only refractory, but also relapsing for 2 years as well. So I surely that Marjorie already checks on the compliance. I think compliance technique, secure catheter, dressing thing. So I surely, so after we already asked asked her about the compliance, so but probably everything is okay. So that's why you finally make decision, right, to remove the catheter.
Yeah, she's a patient who is otherwise quite diligent in terms of taking her antibiotics, exit site care, but
Okay,
just
good, good.
this thing persisted. Yeah.
Thank you.
So
That's a good.
she recovered every time after each episode over the last 3 to 4 years, and it's kind of recovery, and then followed by there's no tunnel track. I think we got a bit worried when the tunnel track happened, and this lady is actually has a mind of her own. Like, she knows what she wants, and she will do what she think is right, that kind of thing. So it's a kind of a real challenge in the real world setting, trying to say, okay, the guidelines, and say no, but he doesn't care about guidelines. Well, I don't want it removed. You know, you remove, I have to take time off, nobody, my children, nobody look after them, and it's whole cycle comes back again. And then she passed from one doctor to another doctor. I don't want to see you, I want to see another doctor. It's very difficult. So finally it happened because pus came out, and there's no other option. Yeah. Yeah.
Thank you so much. Okay, go ahead for the second case.
Okay. Okay, so basically 46-year-old lady, SRF secondary to FSGS. She was actually initially wanted to do hemodialysis, but she had very small veins, and on the scan there was central vein stenosis. So actually vascular recommended either to do a graft or to do PD instead. So she opted for PD. And catheter was inserted in 2018, and other medical issues, basically hypertension, hyperlipidemia, hypothyroidism, but that is well controlled. So again, she presented 4 times for past discharge from the exit site. All the organisms were the same, MSSA. And a second and third time, we actually did ultrasound scan, collections. First one was at the exit site, near the exit site. Second one at the external cuff. And as you can see, at the end of the second and third treatment in March and April 2022, there was actually persistent pus. So basically, it's a case of refractory MSSA exit and tunnel tract infection with persistent pus and collections. But the last scan is basically at the external cuff only. So this is the MSSA isolated, and as you can see, the diagram, the ultrasound scan on the right shows this small 1 cm collection adjacent to above the external cuff. Yeah. So Yeah, I think we can do the poll for this. Basically, it's a refractory MSSA infection, persistent pus, and collections for 4 months. Of note for this case is that the patient has central vein stenosis. So now this latest episode, you restarted oral antibiotic, but what should be the best course of action? Maybe we can see the result.
That's impossible.
How many
That's it.
participants?
You have to reach
Now
first.
it's 30 participants respond to
Okay.
respondent. Okay. For 40 response, so we're gonna show the result.
Okay. Oh, okay.
Okay, yeah, so I think most people got the right answer. Yeah, so the correct answer is option C, to exteriorize the catheter because the collection is at the external cuff. So first option is to try intravenous. Well, based on ISPD guidelines and also as we discussed previously, the first line is to make sure to know whether antibiotic work is that we should have tried intravenous. But the unique thing about this case is that she has central vein stenosis. She's not a good candidate for hemodialysis, and to preserve her on PD for as long as possible, we should try to prevent her from getting worsening infection and peritonitis. So the best would be to intervene surgically if it's a simple procedure. Simultaneous reinsertion after removal. This is possible because there's no peritonitis, but the simpler option is to exteriorize. With simultaneous reinsertion, because it's a new exit site, there is a risk of leak and she may need a short period of interim hemodialysis. But with the central vein stenosis, it may be difficult to insert the tunnel catheter, may cause catheter blockage. So a simpler and better option would be to just simply exteriorize, which can even be done under local anesthesia. Remove the catheter, switch to interim HT is not necessary because in this case, no internal cuff involvement. Yeah. So in this case, we saw exteriorization, which is one of the techniques to preserve patient on PD. So there are a few techniques and there are some guidelines for them. Firstly, there must be absence of peritonitis, no internal cuff involvement, unlike the first case where there was involvement of the whole catheter, so we couldn't do these techniques. And essentially, when you use these techniques, you must continue antibiotics. So firstly, I want to talk about simultaneous reinsertion. The advantages is that you can potentially avoid interim HD by starting low volume PD and so avoid the psychological ordeal of a change in modality and a second surgery at a later time point to insert the catheter back with no GA risk. But there are some predictors of lower success. If there's active infection, MRSA, pseudomonas, fungal, NTM, then usually the outcomes are not so good in the literature. The second way to preserve patient on PD is instead of taking out the catheter, we do this technique called splicing. So splicing basically means that you cut the infected superficial portion, okay, and then you use, so it's basically you expose the infected portion, you cut it, and then you use a titanium connector to connect a sterile extension piece to replace the portion that. So basically you end up with this thing here. So this is a new site. It's where you cut away from the exit site where you want to expose the infected portion. So this is like a new exit site with a titanium adapter and a new portion of the catheter. So then you have the exit site, the old exit site with the remaining superficial infected portion, and basically you just pull it out. Okay, and this is what you discard, send for culture, and this is the end result, 3F. You have the old exit site, remove the superficial part of the infected catheter, and the new exit site where you have the titanium adapter and the new extension piece. Another way is to unroof. So unroof basically means you don't do any cutting. It's like I&D, incision and drainage. So you just expose the infected portion, debride, and soak it in chlorhexidine soap gauze, and then you close up the area. Exteriorization, this photo is a bit blurred, but basically the difference between unroofing and exteriorization is that for exteriorization, after you do the debridement, you actually tunnel the exposed portion of the catheter to a different exit site away from the old exit site. So as you can see in in 3B and 3C, you have an old exit site and then the new exit site. Yeah, so basically this is a summary. Simultaneous reinsertion is usually done when you are concerned that there's colonization of the entire catheter. So for example, if there's a history of maybe internal cuff involvement and then in a later scan, there's no more internal cuff involvement, but you are concerned that it may still be colonized, then you may want to remove the whole catheter and reinsert. Splicing is basically if you are concerned that the infected portion is colonized, the portion that you want to cut is colonized, then you basically cut away the portion, as opposed to exteriorization and unroofing. So this basically you don't cut anything, you keep the old catheter there. So basically when you're not concerned of colonization, short duration of infection, then you can just do simple debridement via exteriorization or unroofing. So basically the last two are the T procedures. The other thing to also take into account is whether the patient can tolerate hemodialysis. So with removal and reinsertion, basically because you are disrupting the internal, it's a new catheter, so you may need a period of interim hemodialysis. The other three options, basically there's no disruption of the internal cuff, so there's no risk of leak and you can continue PD post-op. And studies have shown that actually all these techniques have quite good outcomes. There's actually no comparison across techniques. There's no study that actually compares one technique to another at this moment. But most of the studies show that there's quite good outcomes in terms of infection-free survival, catheter survival, and another study showed the salvage rate was quite high. And another study showed that relapse rate is quite low, only 30%, and catheter survival is up to 90% in 1 year. So this is an interesting study that basically looked at 148 PD patients. 33 underwent this catheter diversion procedure for infected catheter. 115 actually just treated with antibiotics alone. So and basically the graph on the right shows the PD discontinuation and mortality percentage. So essentially what you can see is that the black line, those that underwent catheter diversion, actually have lower discontinuation and mortality rate compared to the red line, which is those that were only treated with antibiotics alone. So essentially it shows that catheter diversion procedure actually can help to reduce mortality compared to just antibiotics.
Okay, question.
I have one more case, but just
Questions
pause
before you proceed?
for any question.
Yes. So would you please spend a minute orientating the ultrasound picture for fellow who may not familiar to the ultrasound imaging for the cuff and tunnel? A minute. Yeah. Because it's quite complicated for the one is not familiar.
Yeah, so basically when the catheter has two cuffs and the cuff basically has this posterior acoustic shadowing. So as you can see, I'm not sure you can see that on the screen, but basically you can see this black portion here is the posterior acoustic shadow. This thick white bar is the cuff. So this is the external cuff. And then this black small little thing at the top of the cuff is basically a collection, which is hypoechoic because it's fluid.
Exit side? Where's exit side?
And exit side is on the right somewhere here. And this is going towards the peritoneum on the left. Yeah, this is just capturing the external cuff. Of course, if you zoom out, then the internal cuff will appear to the left and eventually the catheter enters the peritoneum.
And how about the four parallel lines? Which one, each of them are representing?
So basically the lumen of the catheter is the second, is bordered by the second and the third line. Yeah. So this thing here is the catheter lumen. And these are the walls of the catheter. The first, second, and the third and fourth, those are the walls of the catheter.
I know. Yeah, but for fellow, I think it's good. Thank you. Thank you so much. Anyone want to comment for the second case? Or you can text in the chat box. If no one, so we're gonna move to the third case because we have 20 minutes left.
Okay, so case 3 is a 57-year-old gentleman. He is unable to walk much, only can walk a few steps, very unsteady in walking. The GN patient started on PD in 2023. Of note, recurrent strokes in the past, very bad heart, previous MI, EF only 50-55% with regional wall motion abnormalities, and also a lot of cardiovascular risk factors. Yeah, so he first presented to us in July with pus from the exit side growing MSSA, and this is how his abdomen looked like. So the exit side is on the right, and this is basically where the tunnel tract is, and you can see it's very red, indurated, swollen, tender, and therefore we did ultrasound scan that showed 2 collections at the exit side and mid segment of the catheter. He was otherwise well, no fever, and we gave him a course of oral cefuroxime for 3 weeks, and we repeated a scan when he came back. So when he came back, I don't have a photo, but basically the abdomen looks completely normal now. There's no more pus. But when we scan, there's still a collection, and now it's at a different side. It's at the internal cuff. And so we gave him another 3 weeks of cefuroxime because he was very well. And then we decided to repeat a scan again after 1 more month. Again, patient is very well, but now there are 2 collections. Instead of just his internal cuff, there's a new one at the exit site. But in this episode, we decided that we will hold off antibiotics because the patient has remained well, no fevers. For past 2 months, he has no pus except for at the very start. And so we decided we will just monitor and do a serial scan after 1 month. And then what happened is that when we did the scan, now there's 3 collections and it's getting bigger in size. And so what we have here is a refractory tunnel tract collection without any exit site infection in a patient who is otherwise well. So what do we do in this case? So basically this is the latest scan showing that the collection has gotten quite big, and as you can see here, this collection is stretching across the entire catheter. So this is the external cuff, and you can see the exit side is on the left, and you can see the collection above the catheter from all the way from the exit side to the external cuff. And then the second collection is near the internal cuff, and this black round thing is the peritoneum, and you can see the collection marked by the 2 white, very close to the peritoneum, but it's quite small, 0.5 cm. So this question is based on the case. So we have a patient who has refractory tunnel tract collections with internal cuff involvement, but he's actually very well. Apart from the initial presentation, he is remained well. There's no more pus. His tunnel tract clinically is very well, and importantly, he is not a good candidate for hemodialysis because he has multiple strokes, a lot of cardiovascular risk factors, cannot walk properly, so cannot travel to dialysis center. And so what would you do at this point in time?
Just 20 respondents. We're gonna wait for 10 more seconds. 30. So how many now? 40. So okay, we're gonna stop at 40.
Okay, I think it's quite a mixed response. I think the most common is option A and B. In this case, the correct answer is option A. So let me go through the options. So option A, the reason why we chose this is because the patient is actually very well for past 3-4 months, apart from the initial presentation, and we have not tried any course of IV. So it'll be worth giving him a shot at IV antibiotics because previously it was all oral cefuroxime. Simultaneous reinsertion option B in this case is not the best because now, as you can see in the earlier ultrasound, there's internal cuff involvement, and when there's internal cuff involvement, as I mentioned earlier, we shouldn't do catheter salvage methods when there's internal cuff or if there's peritonitis. So in this case with internal cuff, this is not the best option. Remove the catheter. Of course, this is always the safest. It gets rid of the infection. But as we mentioned, hemodialysis is going to be problematic, potentially problematic for this patient with mobility issues, multiple history of stroke, and ischemic heart disease. Then there's this option. So, so basically, IV antibiotic is going to avoid all the risks, potential risk of hemodialysis, and also taking into account the GA risk when you remove the catheter. Of course, we can also choose to keep holding off antibiotic, but as you can see, the collections are getting larger. And so it may indicate that the infection is actually still there. So basically leads to the question. So before that, just to summarize the case. So basically we have enlarging collections, previously oral antibiotic in a patient who is not a good candidate for hemodialysis. So because the patient is well, we decided that we will give him a shot at IV. But this patient was quite stubborn. He wasn't agreeable to admit for intravenous antibiotic, and so we decided we will use intraperitoneal. Of course, we cannot measure cefazolin levels in the blood, and there's questionable peritoneal absorption. But what happened is that after we gave him a course of IP cefazolin, the internal cuff collection disappeared, and we only left with external cuff collection. So after that, we only have this external cuff, and now with external cuff, no internal cuff involvement, we can actually do exteriorization. So this is after post-op. So as you can see, his catheter was exteriorized. This is the new exit site and the old exit site. And he did quite well post-op, but subsequently he had other cardiovascular complications unrelated to this infection. So as you can see in the previous case, in a patient who is very well, but with ultrasound finding, how do we correlate these radiological findings clinically? What do we make of all these scan findings, persistent collections, or if they're very small collections in a patient who is well, how do we decide whether it's significant or is it just incidental or sterile collections? So there are a few studies, and there's a review by Nadelli that actually came up with this proposed flow chart. It's not based on very strict, clear guidelines, but it's just a proposal. So on the right here, basically you have a patient with exit, tunnel, and peritonitis. In this case, basically the recommendation is to intervene surgically by SCR, simultaneous catheter removal reinsertion, or removal. On the extreme left is exit and no tunnel tract, no peritonitis, so pure exit site infection. And in this case, you can just give antibiotic. So what do you do if you have exit and tunnel tract infection, like in our earlier case, but no peritonitis? So after giving a course of IV antibiotics, you can actually scan again. And what this review suggested is that based on other studies, if the decrease in size of collection is more than 30%, you can continue with antibiotics. But if the collection decrease after 2 weeks of IV antibiotic is less than 30%, you should consider surgical intervention. So if collection reduced less than 30% after 2 weeks of IV, this review recommend to proceed to surgical intervention. Another way is to use the size and Doppler. So if the collection is less than 1 mm, it could be an infection and you may want to repeat a scan. If it's more than 1 mm, it could be an infection, but you also should take a history to exclude other causes. If the patient is otherwise clinically well, no fever, you might want to ask for any history of trauma, whether there's a recent catheter infection that resulted in the collections. Another way is to use Doppler signal. So positive Doppler would be more suggestive of an infective process, and negative Doppler may indicate a resolved infection, sterile collection, or even potentially a leak. So taking a history is always very important. Okay, and this is my final second last slide. Basically, we have talk a lot about how to manage infections, but the best is always to stop happening lah. So prevention, there are many arms. Peri-op, post-op, when we insert the catheter, usually we recommend to give, ISPD recommends to give antibiotics. If a patient MRSA colonized, do decolonization. Also recommend to leave the site unexposed for 7 days to allow it to heal. Careful selection of exit sites so the patient can clean properly, and to minimize leaks, to make sure the exit site is well healed, and to wait at least 2 weeks before you start. Exit site care. In our center, we recommend daily exit site dressing change, and as well as after the dressing is soaked, for example, showering, or if patients sweat. Proper immobilization to prevent tugging of the catheter, use of soaps. In our center, we also use a biopatch, which is a chlorhexidine impregnated sponge, which is more convenient because it can be, basically you just need to change it weekly compared to daily dressing, but there's a risk of contact dermatitis. And of course, regular home visits. Then ISPD has a few topical antibiotics that are recommended. In our center, we use gentamicin most commonly. And of course, after one infection, we should always take the opportunity to assess and educate the patient when another episode from happening. So assessment includes whether there's any deterioration in eyesight that affect the patient from cleaning properly, any contact dermatitis, improper anchoring, and very importantly, we should always ask whether there's any change in the caregiver. So in summary, we have seen that the best is to prevent infection, but when infection happens and antibiotic don't work, there's always this balance between preserving the catheter, intervening surgically, and I hope that through the 3 cases and the discussion, in some of the factors that we should take into consideration, especially the comorbids and patient preferences. So in summary, the ISPD recommends center monitoring, prevention, and treatment. But I think the most difficult decision that we always face is whether to remove the catheter and then switch the patient to hemodialysis and use that modality. And as I think, hopefully through the 3 cases, this process, taking into account comorbid preferences and the discussion between patient and nephrologist. So it's my last slide. Thank you all for your attention, and any questions that
Any question from the floor? You can text to the chat or you can voice you. Anyone?
Maybe and only the last slide, which is the ISPD guidelines.
If no, so I would like to thank everyone for spending your time with us today, and big thank to Dr. Chilu, and also sincere thank Marjorie for an excellent, highly practical case discussion, and also for thoughtful highlighting and important gaps in the 2023 ISPD guideline that is often overlooked in our daily practices. And also apology for typo on my timetable on the flyer from AM to PM. So that why many attendees from India and Pakistan cannot engage us. And the recording will be uploaded to the YouTube soon. So the link is sharing, so you can pass it to your colleague and your trainee before we end as usual. So switch on your camera so we can take a quick group photo. So I think this session we got almost 140. Really wonderful, excellent. Even India and Pakistan and Bangladesh cannot involve us. So probably if with that gonna be more than 200.
Oh. Okay.
So while we are smiling, so a quick announcement. So we're gonna skip December, and our next CPC will be on January 20th, 2026, hosted by Blue Nile. please mark your calendar. And now
Mm.
I'm pleased to hand over to Lily. Please say something before we gonna close the session, and
Okay,
also Marjorie as well.
yeah, I think I let Marjorie, you're the supervisor. Just to thank you, Dr. Sherry, for the great presentation of the 3 clinical case from your experience in Singapore. Thank you. Yes, Marjorie, I pass it to you.
No. When we presented yesterday, we were rehearsing. I said, "Wow, this is like washing our dirty laundry in public." Like we are not following ISPD guidelines. We're going against guidelines. But I think in the real world experience, we all use guideline as our backbone, right? But at the end of the day, you just have to see what you can do for the best for the patient. Like patient can't chemo, cannot afford chemo. You have no choice but compromise, and hopefully at some point, it will work, lah. And I think it's and I also find that ISPD guidelines recently has become more and more vague and more generalized, that rather going to specific. But I think for the fellows is that it is never a wrong thing to do, but think of the patient, what's best for the patient, and using the guideline as a backbone to figure out whether it's the right thing to do. Yeah.
Agree. Yeah, thank you.
Okay.